I'm Winfried Amoaku, a consultant ophthalmologist in Nottingham University Hospital and associate professor in the Nottingham University. Well, several issues. One, that diabetes is on the increase, and therefore diabetic retinopathy or diabetic eye disease is on the increase. Okay, and we know the longer you have been diabetic, the more likely you are to have eye problems, and especially if you're not controlled. So if we have more diabetics who are living longer, and especially as some of them are not well controlled, with increasing obesity, we have a massive explosion of diabetic eye disease. And although we all talk about the retinopathy, other parts of the eye can also be affected, including the cornea. And the eye becomes less sensitive, and if you develop a corneal aberration, it heals less well if you're diabetic compared to if you're not. So if you put all that into context, diabetic retinopathy or diabetic eye disease is on the increase, its severity is increasing, and we need to put more resources towards its detection and treatment. Traditionally, we treat diabetic macular edema with laser photocoagulation. Okay, but now, fortunately, we have pharmacological therapies as well, because we understand the disease much better, and therefore we use focal laser in eyes where the leakage or the diabetic macular edema is localized and doesn't involve the center. But once the macular edema involves the center, laser, and is diffuse, laser is no use to you. And that's where the pharmacotherapies become important, but we have to inject these drugs into the eye. So the different pharmacotherapies, two classes, what we call anti-vascular endothelial growth factor drugs or anti-VEGFs, and then the steroids. Steroids are useful in especially macular edema that has been present for a while, or chronic macular edema, and for those, steroids will reduce the edema a lot more than anti-VEGFs. But if it's early, we will use anti-VEGFs, either ranibizumab or Lucentis or aflibercept or Eylea. And of course, there's the unlicensed option as well of bevacizumab. So depending on whether the patient, NICE limits which ones we can use, depending on whether the patient has a natural lens or whether the eye is pseudophakic or not. If it's pseudophakic, you can use the steroids once the center is involved. And the steroids are Ozurdex or dexamethasone implant or fluocinolone implant. Okay, so if the eye is pseudophakic, you can use either of those two. Ozurdex lasts for 3 to 6 months, whilst fluocinolone lasts for 2 years or more. Now, either of those can cause slight pressure problems in some patients compared to others, so we sort of select who we want to give it to and who we don't. But generally, the pressure problem is not as much as has been made out, and especially as you can treat some of those pressure problems. Okay, whilst sometimes you don't have any alternative for the macular edema. If the patient has a very thick or boggy retina where the macula is thicker than 400 microns, according to NICE, you can use either ranibizumab or aflibercept. But those require monthly injections until things are stable, and then you treat appropriately. Absolutely. The diabetologist is important in the management of diabetes, because apart from the duration of diabetes, the control of diabetes determines whether the patient develops retinopathy and the severity of it as well. So the more controlled the diabetes or the blood sugar over a long period, rather than just short term, the better the chances for the eye not developing severe disease. That's the first thing. And secondly, we also know that high blood pressure or hypertension and high cholesterol or hyperlipidemia sort of modulate the progression or development of diabetic retinopathy. So the general physician and the diabetologist will monitor the blood sugar and the blood pressure as well as the lipid levels and treat them appropriately. And these will work towards supporting the eye and what the ophthalmologists do in the management of diabetes, the diabetic eye disease, whether it's the macular edema or the proliferative disease. So yes, it has to be collaborative and that we should work hand in hand.